Good day, my name is Farouc Jaffer from Mass General Hospital. I am delighted to be part of Scottsdale Interventional Forum 2020, and I thank Dr. Reisig for the opportunity to share with you an insight into Precision PCI, the link between OCT use and lower major adverse cardiac events. These are my disclosures. So what is the rationale for intravascular imaging in PCI today? Well, despite our best generation, second and third generation stents, we still have an Achilles heel of restenosis. This is some very important work from Madhavan and Stone, published in JACC earlier this year, showing that despite our best approaches, we still have significant MACE rates at 5% at year one, but more importantly, from year 2 and onward, there is a persistent 2% MACE rate per year indefinitely, at least up to year 5, and we'll find out if it's even longer. This is a major Achilles heel. If one maps this out over 10 years, that's an approximate 20% MACE rate. And most of that MACE is really driven by restenosis. Restenosis is not benign. It leads to reintervention, brachytherapy, and bypass surgery. And we know that intravascular imaging can now reduce restenosis by optimizing stent expansion, recognizing edge dissections and covering them with additional stents, and avoidance of placing stent edges in high plaque burden areas which can predispose to dissections and revascularization. This has really probably crystallized the efficacy of intravascular imaging based on the recent ULTIMATE trial. We had prior IBIS trials with IBIS XPL and CTO IBIS, and the ULTIMATE trial was even a broader study showing that there is over 50% reduction in target vessel failure. It's really driven by target vessel revascularization, but there were trends to lower cardiac death, MI, and stent thrombosis. And they found that specific IBIS success criteria really allowed a fantastic outcome when using image guidance. And that's typically obtaining a stent that's big enough with a mean stent area greater than 5 square millimeters, or in smaller vessels, more than 90% of the distance reference area. Not landing stents in edges of high plaque burden within 5 millimeters of the stent edges, and then avoiding edge dissections, typically of longer lengths that are deeper, involving the media. So why is OCT potentially an alternative to IBIS for guidance of PCI? Well, we know that OCT can provide higher resolution. There's an exquisite luminal border detection that allows auto-segmentation. It can see thrombus dissection, hematoma, and stent strut definition better than IBIS because of really a 10-fold increase in radial resolution. OCT is limited, however, in terms of its depth penetration compared to IBIS. This sometimes can make difficulty to identify the external elastic lamina, which allows us to be able to define the stent geometry. Contrast is a typical requirement right now, and this can limit our use in CKD patients in cases where we need to have multiple runs. And of course, contrast makes it difficult to use for real-time IBIS or PCI guidance. Nonetheless, because of OCT's resolution, the ability to see plaque composition is greater. Examples here looking at the differences between simultaneous or sequential OCT and IBIS, and thanks to Dr. Ali for providing the slide. I'm really showing the improved ability of OCT to look at fibroflatty plaques and to look at calcium and really calcium thickness, which is hard to do because of acoustic dropout that occurs as soon as calcium is detected by ultrasound. We do know that OCT, because of its challenges to see deeper, at times can limit the ability to provide optimal stent sizing. However, there have been improvements in this area. But historically, because it was easier to size OCT vessels based on lumen to lumen, one would recognize that OCT might slightly undersize compared to EEL to EEL measurements provided by IBIS. Some additional limitations that we know from angiography is that we have an inability to look at calcium. OCT is very good for looking at calcium, and work from Akiko Mahara at Columbia demonstrated that calcium detected by OCT, if it's wide with an arc greater of 180 degrees, or thick greater than 0.5 millimeters, or long greater than 5 millimeters long on the axial artery, when these three features conspire, there is a very significant high rate of underexpansion. This means that if we recognize this ahead of time, that we can actually use calcium modifying therapies such as atherectomy or scoring balloons, cutting balloons, to be able to avoid an underexpanded stent. OCT is fantastic for looking at edge dissections. Again, the exquisite resolution really allows us to look at tears. We can then identify whether or not a dissection might be major, if it involves a wide arc, if it's deep, if it's near the stent edge, of course, if it's flow limiting or really leads to a small lumen. These are situations where an additional stent placement makes sense to ensure optimal outcome. Well, have there been OCT trials? There certainly have been a number of randomized trials. These have typically been against angiography, not really designed for clinical endpoints, but looking at surrogate endpoints. OCT guidance provides more stent coverage, a higher FFR, and a larger stent volume than angiographic-based assessments alone. Compared to IBIS, we have seen smaller stent sizes, but with an EEL-based strategy now increasingly being adopted, for example, in the Lumion 4, OCT can provide similar stent expansion versus IBIS. And ultimately, we're going to see this play out in upcoming trials. What about success criteria? How do we know if we've done a good job by OCT and IBIS? Well, it turns out that we have a number of different criteria, and this can make it confusing. A simplest criteria is to make sure that your stent is bigger than your distal reference segment. In reality, you can actually use that and get to 90% of the distal reference segment. For OCT, we're looking for greater than 4.5 square millimeters at the distal segment, if not diffusely diseased, and getting a minimal stent area within the stent of greater than 80% of the mean reference. That's when we average the proximal and distal. We're going to learn some more from upcoming key trials. The Lumion 4, as I alluded to, is going to be a definitive study, we hope, against angiography, with the hypothesis that OCT guidance is superior for angiographic guidance. It is a 1-year target vessel failure endpoint, and there's going to be a post-PCI OCT in the angiographic arm that's going to be blinded to the investigator. That is a nice feature to help us understand mechanisms of an expected improvements with OCT guidance. The OCT IBIS study is being run by S.J. Park. This is 2,000 patients ongoing, 3 sites in Korea, expected to be out in December 2021, randomizing a wide inclusion criteria of patients with OCT and with PCI to either OCT or IBIS. Exclusions are STEMI, CKD, shock, or ejection fraction less than 30%. Primary endpoint, 1-year target vessel failure. Follow-up is going to be out to 5 years. So how can we actually use OCT now to enable Precision PCI? This is a really excellent algorithm, really summarizing the work that's been done by multiple groups, published by Lee and Sir in the Korean Circulation Journal. OCT can be used ahead of stent placement to understand stent dimensions, avoid landing in high plaque burdens, and assessing calcium burden. So we perform calcium modifying therapies for certain lesions of high calcium intensity. When the EEL is present, one can then measure the EEL diameters in 2 different dimensions and then downsize to the nearest stent. If the EEL is not available, then using the mean luminal area based on the internal luminal border, and then upsizing to 0.25 millimeters is an algorithm. The stent length is easily determined based on OCT auto-segmentation, and again, if heavily calcified, be prepared to modify. The next step is to deploy the stent at moderate to high inflation. Step 3 is to do an angiogram, and if there's a visible stenosis, to post-dilate. After eliminating angiographic stenosis, then proceed to a post-PCI evaluation. For this area, we're looking for really 4 different areas. We're looking to maximize our expansion, as we talked about, trying to get greater than 4.5, greater than 90% of the distal reference or 80% of the average reference. We're trying to avoid gross malapposition of more than 200 microns. If we see that, we want to post-dilate. If there's a significant edge dissection, we're going to need to implant another stent. And if there's tissue protrusion that is substantial or bulky, we may consider strategies like potent DAP, in some situations laser. What we don't want to do is do additional high aggressive post-dilatation. This can sometimes worsen it. Restenting is another option as well in these situations. This has actually made it into consensus guidelines, and I encourage the aficionados to look at the EHJ paper published by Lorenz Laber and colleagues. It really comprises both IBIS and OCT goal criteria. And one is to really ensure that we have a minimum stent area that is greater than 5.5 by IBIS, 4.5 by OCT, and trying to get 80% of the average reference lumen. We want to avoid dissections. We want to avoid gross malapposition, no extensive protrusion, and avoid landing the stents at edges of high plaque burden greater than 50%. In the future, we're going to have multimodal catheters. There's a combined IBIS OCT system. We have a NIRS IBIS system. Fluorescence OCT IBIS is developing, and an OCT near-infrared spectroscopy catheter is going to be developed. These are going to allow us to have even more comprehensive wall information for optimizing stent implantation. So in conclusion, for OCT and Precision PCI, OCT can perform similar to IBIS in randomized trials of routine PCI, especially for more aggressive sizing using EEL to EL measurements. An algorithmic OCT approach can optimize stent outcomes, and Illumium 4 and OCT IBIS RCTs that are coming up will provide key data for determining if OCT can improve clinical outcomes. And thank you very much for your attention. Again, a pleasure to be part of virtual SIF sessions. Thanks so much.